There's also been diversion within nursing homes or home care organizations or other things like that. And then counterfeit prescriptions. So what I'm talking about here is not somebody faking writing out a prescription. I'm talking about illicitly produced counterfeit prescriptions. So for example, last year there was a series of overdoses, and the people had taken what they thought to be was Oxycontin. So they had bought Oxycontin from somebody on the street. It was way cheaper than their copays, so it made sense to buy it in their mind, except for it turned out to be cocaine and fentanyl. So if someone has the physical tolerance in their body of Oxycontin, a commonly prescribed opioid, then obviously those other drugs are going to cause an overdose. So we see a lot of counterfeit prescriptions. So they're produced in mass quantities at pill mills throughout the nation and overseas. And then the fifth source is illicit drugs, heroin, fentanyl, and fentanyl analogs. So each of these different sources has the different levers of change. So obviously if we're working on improving prescribing practices, that's really only going to get to the first source, the prescription to the patient. If we're working on safe disposal of unused or expired medications, that really gets at that second source. And then the rest of these sources, diversion, illicitly produced prescriptions, and illicit drugs, that falls more into the law enforcement sector. So at the end, I'll pull up the opioid dashboard, but I just want to say it's really easy to find. You go to Google, write opioid dashboard, it's the first thing that comes up, or you can go directly health.state.mn.us/opioid dashboard. And at the top of the page, you'll find contact information for my colleagues at MDH, and feel free to email in specific questions. For example, if you want to look up your county's rates for overdose death or prescribing, or if you have a media inquiry, if you want to work on a story, there's all contact information. Or if you want to talk about how this is impacting policy, there's a contact for a policy person as well. So that's how you find it. Google opioid dashboard comes right up. So next I wanted to tell the story of the three sisters. How many of you have heard this story, this parable? You've heard? Okay, great. All right. So there was three sisters that were walking along the river, and all of a sudden they saw a bunch of babies in the water. And the first sister swooped them out of the water, and the second sister got in and helped them along, and the third sister ran upstream to see why they were falling in the river in the first place. And this parable has been told forever to talk about the importance of upstream or primary prevention. But instead, we want to talk about how actually we need all three sisters doing better at the same time in order to address this opioid epidemic or this drug epidemic. We have to save lives, we have to address the harms that have already happened, and we need to prevent harms from happening in the first place, all at the same time. Next, I'm going to share some data from MDH death certificates on opioid overdose death. Opioid overdose deaths have been increasing from 2000 to 2017. The blue line is the total opioid-involved deaths. So in 2017, there was 422 Minnesotans that died of an opioid-involved death. The green line would be what we would consider commonly prescribed opioids. So it's important to note that these are actually still the leading cause of opioid-involved death in Minnesota. You can see that the line started to level off around 2010. And then you can see these other lines, the red and orange line, that they're quickly catching up. And the orange line is likely to surpass the green line in the next year. So there's really been three waves in the opioid epidemic, nationally and in Minnesota. The first being prescription opioid-involved death, the next being heroin-involved death, and then the most recent surge, which you can see is so dramatic in the orange line since 2015, is the fentanyl and fentanyl analog-involved deaths. So I want to note that fentanyl can be a prescription. This would be fentanyl, like a fentanyl patch for a terminal illness or cancer-related pain. However, when we're talking about these fentanyl-involved deaths, we're talking about illicitly produced fentanyl that is other drugs are cut or laced with fentanyl. In Minnesota, we've seen cocaine, heroin, meth, all cut with fentanyl and fentanyl analogs. So it's important, even if a person's drug of choice is methamphetamine, it would be important to understand that opioids, fentanyl may be included. The next thing that I want to talk about is the race rate disparity in drug overdose death. So in Minnesota, we're actually our overall mortality rate is one of the lowest in the nation. So when we're trying to get resources for our state, we actually don't bubble up to the top as one of the states needing the most support. But when you break it down by race, then we actually have the worst race rate disparity in the nation. So the blue lines are 2015, or the green bars are 2016, and the purple bars are 2017. And so what this graph shows is that African Americans are more than 2 times more likely to die of a drug overdose than whites in Minnesota. And American Indians or Native Americans are more than 6 times more likely to die of a drug overdose than whites in Minnesota. The American Indian rate of overdose death, 76.2, is the highest in the nation. So when we look at other states that are suffering way more than Minnesota, our own Native American population has a higher rate than anywhere else. Yeah. Per 100,000. Yep. 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 So what's important to note here is that the rates are increasing for all groups, and the disparateness between the groups is also increasing. So when we worked with the governor's office to make the opioid action plan, we made sure to share this data, and this actually made it into the front of the opioid action plan. And to say that any program, policy, or funding decision from here on out has to take into account a race rate disparity, or we're going to continue to see the disparity increase. So now we're going to talk about non-fatal overdose. How many of you have heard of naloxone or Narcan? Same thing. So tissues, Kleenex, right? One's just a brand name. So naloxone is the medication that blocks the effects of an opioid during an opioid overdose emergency. Naloxone is available from a provider, and there are guidelines for when a provider should be co-prescribing naloxone. It's also available from pharmacies, any pharmacy that participates in the naloxone protocol. So the naloxone protocol was passed in, I want to say, January of 2017. And what it says is that any pharmacy can dispense naloxone to anyone who's at risk for or knows somebody who's at risk for a drug overdose. And that third-party prescribing piece is really helpful because a lot of times we hear from family members, there's just nothing I can do. My hands are tied. I just feel like I'm waiting for something terrible to happen. And this is a very concrete action step that any family member could take, and actually anyone could take. So our last commissioner, Commissioner Ellinger, gave a press conference on this and really encouraged anyone in Minnesota, just as you would go get CPR certified so that you could be a good Samaritan and intervene in an emergency. This is another thing that you can do. You can carry naloxone so that you are prepared to intervene in an opioid overdose emergency. The third group that carries naloxone is first responders. MDH provides funding to each of the 8 EMS regions to carry naloxone. And then DHS provides funding to community-based organizations to provide training and kits at no charge to the community. So the recommendation is to provide naloxone if you come upon someone who's unresponsive and you're uncertain why. Naloxone will not work if they are unresponsive for a reason other than opioids, but it also won't hurt if they're unresponsive for a reason other than opioids. And you simply can't tell if somebody is unresponsive because of drugs or not. We have in Minnesota, we're lucky to have the Good Samaritan Law, or Steve's Law, which is the legislation that provides limited immunity to anyone who is responding to an opioid overdose emergency and acting in good faith. Now, it's still going to be an emergency situation. So when police respond, it's possible that you could be detained. It's possible that you could be cuffed. That's simply to secure the area. It is an emergency situation. But anyone who administers naloxone acting in good faith has immunity because of Steve's Law. We have a video here. Now if I can, this is really short, if I remember how to do it. Sure. There it is. What? Oh, it's not working. I'm forgetting how to do it. No, we tried that at the beginning. It's not working. So just 1 second. There we go. Sometimes I just need to call for backup. Okay, there we go.
So the signs and symptoms of an opioid overdose are, 1, you can't get the person to respond to a pain response. So you take your knuckles and you rub them firmly on their sternum. If they do not respond to that, that's a key indicator that they've overdosed. Another indicator would be blue or palish lips and nails. Another indicator would be their breathing. Is it really shallow? Is it raspy? Is it paused? So there's no breath sound and then a big gasp. Those are all indicators that somebody has overdosed.
So I just wanted to point those out. On the opioid dashboard, there's a whole series of videos that are free for you to watch and use as a part of any training that you're doing. Okay, what's happening here? I might need help again. Is it moving now? Okay, it's moving now. I'm good. Thank you. Technology is not my expertise here. Okay, so now we're going to shift a little bit and talk about opioid use, misuse, and substance use disorder. So in opioid use, what we really want to focus on here is that patients are empowered to make decisions about their own health care. And the acronym, how many of you have heard of the BRAIN acronym for informed decision making? Great, one of you. So this is commonly used in nursing. And it's a decision-making tool for patients to think through their options and be a part of that active decision-making about what's best for them. So BRAIN stands for benefits, risks, alternatives, intuition, and no, not now. So for example, let's say you have an acute injury or surgery, and your provider is recommending opioids, then you can talk about what are the benefits of opioids, what are the risks of opioids, what are my alternatives to taking opioids, what is my intuition telling me about taking opioids, and what if I say no, not now, right? And so it may in fact be that the decision that's arrived at is that opioids are the best option for that circumstance, but at least you've talked through it and you understand the benefits and risks and really the plan around it. Second, I want to make sure that we understand what a substance use disorder is. So a substance use disorder is defined by a set of criteria that is set in the Diagnostic and Statistical Manual, or the DSM-5. For a mild opioid use disorder, you need 2 to 3 criteria, and those would look like things like taking the opioid in larger amounts or for longer than intended. So this would be if a provider recommended something where it was 15 milligram pill once a day, but actually that person was taking 3 of them a day. having cravings or a strong desire to use opioids. So this might be someone who is getting to the end of their prescription and is already starting to be concerned about or figure out how to get a refill, or feeling that dependence already happening within their body. Wanting to cut down or quit and simply not being able to. Spending a lot of time obtaining the opioid, so you may have heard of the term doctor shopping, or where somebody goes to multiple providers or multiple pharmacies, or veterinarian, we talked about that. And then continued use despite problems. So one of the fundamental features of a substance use disorder is that despite any problems that are going on in family life, with work, with their body, somebody is continuing to use despite those problems. And then DHS launched the Fast Tracker, which is a statewide treatment locator for mental health and substance use disorder. And you can search by location, the type of treatment, so inpatient, outpatient, residential, or by any keyword. If you were looking for a buprenorphine program or an adolescent program or Spanish speaking, things like that. This can be used by anyone, a provider, a loved one, the patient themselves. Opioids have received a lot of attention, and while there are many drugs out there, opioids are one of the most fatal because of the respiratory depression. However, even with opioids, death is the most profound impact, but death is actually the smallest impact in terms of the numbers. For every one opioid-involved death, there's 2 opioid-related hospital admissions, 4 opioid-related emergency room visits, 7 opioid-related EMS runs, and 30 opioid-related treatment admissions. So we really start looking at what creates the demand for altering substances in the first place, and that at the root of most substance use disorders is pain, trauma, and suffering, whether that is physical pain, emotional, psychological pain, trauma, or all of the above. Now we're going to take a look at some data. This is drug treatment admission data, and it shows the primary drug at the time of admission into treatment. It's from DANES, which stands for Drug and Alcohol Abuse Normative Evaluation System, quite the mouthful, but DANES data, and it's from the Department of Human Services. So this is a time lapse. It starts in 1995 and goes all the way through 2017, and it's showing admission for heroin, other opioids, which would include opioids, prescription opioids, fentanyl, and fentanyl analogs, and also methamphetamine are included in this data source. So you'll see the numbers start to show up, and that dotted line is showing injection drug use, the rise in injection drug use. You'll see a peak of methamphetamine in 2005, and then a sharp decrease. That's after legislation was passed to limit the production of methamphetamine in Minnesota. And so methamphetamine kind of comes back down in line with the other drugs. Then you can see other opioids starting to come up, then heroin coming up, methamphetamine rising so much. So there's just so many things to recognize about this graph. We could probably take a half an hour just talking about this, but I want to point out a few things. One, I think we all can remember the methamphetamine drug epidemic in 2005, and treatment admissions are more than double what they were at that time now for methamphetamine. Number two, I think we all know that around 2000, the opioid epidemic for prescription drugs really started taking off, and now look at where we're at of the drugs that are used in an injection drug use way. So it's important to recognize that when we saw those 3 waves, right, the prescription opioids, the heroin, and then the fentanyl analogs, not only did what was causing the deaths change, but the route of use is changing. So people used to be swallowing or snorting, and now we're moving more into snorting and injecting. The increase now is in methamphetamines and opioids, and the opioids being heroin, fentanyl analogs. So really more than an opioid epidemic at this point, we have an injection drug use epidemic and a substance use disorder epidemic. For prescribing practices, there was a work group established in 2015 called the Opioid Prescribing Work Group, and it was made up of providers, mental health providers, medical providers, labor and industry, pharmacists, patients, all sorts of different specialty areas. And they worked together to create the acute, post-acute, and chronic pain guidelines. And they were published the fall of last year. And they built off of other guidelines like the CDC's guidelines or ICSI, the Institute for Clinical Systems Improvement. And it's a huge document that you can take a look at. However, to break it down as simply as you can, for acute pain, it simply says, prescribe the lowest dose and duration that's clinically necessary. So instead of any kind of standard, 30-day supply or something like that, really looking at how many actual pills an individual needs. And it might be 4 or 7 or 10, and that you provide the lowest dose and lowest duration that's clinically necessary. For post-acute pain, so post-acute pain is following an acute injury or surgery. The idea is to prevent the development of new chronic use. So not providing refills if at all necessary, and looking at the integration of other modalities at that point, if at all possible. And if a refill is needed, then actually increasing the engagement, increasing the number of visits, and staying closely connected to somebody during their healing time. And then for chronic pain, there's kind of two very different recommendations. So one is, if somebody is already on chronic opioid analgesic therapy, that person needs to be incredibly carefully managed, potentially tapered, a taper at least discussed, maybe integration of other treatment modalities, non-opioid treatment modalities or non-pharmacologic modalities. That's that group, somebody who is already prescribed chronic opioid analgesic therapy. For anyone else, it's about not developing new chronic use, not initiating new chronic use with anyone else. So really important to recognize the two different groups, because nowhere in these guidelines does it say to abruptly discontinue anyone from opioids. That is the most risky thing you could do. The other thing I wanted to mention about prescribing practices is that the Prescription Monitoring Program puts out annual reports that show the crude rate of opioid prescribing per county. So you can actually look up your county's opioid prescribing rates over the last few years to see how they've changed, and also to see how they rate compared to other counties in the area or the statewide average. The Prescription Monitoring Program is a system run by Minnesota Board of Pharmacy that tracks the prescribing that is inside and outside of the clinic system you're working in. So instead of just having the electronic medical record and whatever happened at one particular clinic, you're seeing the full prescribing history of that patient to help inform clinical decision making. And it's now mandatory to have an account with the Prescription Monitoring Program for anyone who can write a prescription for opioids. In supply diversion harm reduction, so we talked a little bit already about where opioids come from. So that first part, sharing, we talked about sharing opioids with family members or friends. The Minnesota Pollution Control Agency hosts a statewide searchable database of safe disposal drop boxes for unused and expired medications. So you can search on there and find out where the nearest drop box is. It's required that sheriff's offices maintain a safe disposal drop box area, and that's in Minnesota statute. And then it's optional for any law enforcement officer pharmacy to also carry safe disposal of unused or expired medications. Certainly there are considerations there, right? Do you have the space in your pharmacy? Do you have staff who can be present and observe the box and things like that? So not all pharmacies participate, but many, many do. And then when we talk about novel substances, so novel substances simply mean new, a new substance. There are new fentanyl analogs on the drug market every day. The DEA actually passed emergency scheduling for all fentanyl analogs so that they were able to prosecute. They couldn't even stay up to date on all the new analogs, and so they had to create this umbrella term, this emergency scheduling, for all fentanyl analogs to be able to move forward on prosecutions related to analogs. So, well, there's going to be these different trends and different drugs popping up. As a public health entity, we wanted to look at what is the consistent messaging that we need to be sharing with the public, regardless of what it looks like or the current drug that came because of the basketball tournament or whatever it may be. What's the consistent messaging all the time? And what that is if you buy a drug on the street or possibly even online, you don't know what you're getting. And the color and appearance actually says nothing about the contents or potency. So just because it's a pink pill or a green pill or a gray pill doesn't tell you that it's the same as something else that you might have taken. And we have to assume at this point that most or all counterfeit prescriptions and illicitly produced drugs are unpredictable and adulterated. And adulterated meaning that they contain multiple substances, they're laced with or mixed with multiple substances. So Minnesota Department of Health is engaged in this pilot project, Mendoza, where we're collecting samples from hospitals and testing what drugs are present. And in the vast majority of the cases, the drugs have contained multiple substances. So what we know to be true is that even if a person's intent is to take one such drug, and something that they may have taken before, what we know about the drug supply now is it's changing rapidly and that it contains multiple substances. And obviously when you're having things that have different effects in the body, uppers and downers at the same time, leads to a very confused central nervous system. We don't have time to watch this video, but I just want you to know that it's there. It's called Fentanyl, the Real Deal, and it really goes through and breaks down some of the myths about fentanyl and also summarizes the concerns. It's set up for a first responder audience, but it's a good video about fentanyl. And then harm reduction. So the idea of harm reduction is that if drug use is happening, what can we do to reduce the harms associated with the drug use? So nationally, about 1 in 10 people get into treatment and recovery supports. 1 in 10. So for the other 9, we have to make sure that we're doing everything we can to reduce the harms that are associated with drug use in the meantime. Right? Certainly we hope for recovery and treatment supports for all people at some point, but in the meantime, what can we do to reduce the harms? So some of the most simple harm reduction medication is one, to carry naloxone, the medication that blocks the effects of opioids during an overdose, to train those around you to use and carry naloxone. So obviously if you're overdosing, you're not going to be the one to administer naloxone to yourself. It's going to be somebody around you. So it's very important if you know somebody who uses drugs that their roommate, their loved ones, their neighbors have naloxone available. And then the best recommendation is not to use alone. If a person was going to use alone, to text somebody before and after use, to use in an unlocked room, and to have naloxone nearby so that somebody could find them. And then also to have a safety plan for every time you use. So just as if a group of friends was going out drinking, they would look at who's going to be the sober cab, don't take any open drinks, drink some water between drinks, things like that, safer use guidelines. It's a similar idea here, is what can be done to have a safety plan for each time that a person is using, and safety as in staying alive, sexual safety, avoiding wounds, all those things. So MDH funds syringe service programs in Minnesota. Syringe service programs provide services to reduce the harms of drug use and to prevent HIV and viral hepatitis. The programs that we fund all provide HIV and Hep C prevention, testing, and linkage to care, naloxone kits, education about overdose prevention, including safer injection practices, sterile syringes at no cost, sharps containers and safe disposal of used syringes, and then referrals to medical, mental, sexual, chemical health resources. So if we haven't already gone over this, the need for syringe services in Minnesota is more than ever. There's been a 300% increase in injection drug use in Minnesota in the last decade. We're seeing all of these novel substances appear in the drug marketplace. There's more than 34,000 Minnesotans living with hepatitis C. Hepatitis C, the injection drug use, is the #1 risk factor for that. And last year alone, there was 284 new cases of HIV. So all of those things put together create a dire need for syringe services programs at this time. So some of the benefits of syringe service programs: 1 in 3 officers are stuck with a needle during their career, and syringe service programs provide education and resources on proper disposal for people who use drugs. In 2018, the MDH-funded SSPs took in more than 550,000 used needles. So these are used syringes that are not in parks or in garbages that aren't sterile ways of disposing. So the research shows that when a syringe service program comes into a community, it reduces needle stick injuries by 66%. We know that more than 400 Minnesotans died of opioid-involved deaths in 2017. SSPs teach people who use drugs how to respond to an overdose emergency using naloxone and how to prevent overdoses through safer injection practices. Research shows that SSPs do not increase drug use in any study. There's never been an increase in drug use when an SSP comes in. The third is that they reduce the incidence of HIV and hepatitis C infections. So sharing equipment is what transmits these infectious diseases. So when people have access to sterile syringes and other supplies, then those diseases aren't transmitted between people. The SSPs routinely provide testing. Last year, 14% of the Hep C tests that were conducted were positive, and SSPs provide that linkage to care to reduce the transmission. The fourth thing is that they reduce the infectious disease treatment costs. So the return on investment is very simple. Sterile syringe is a couple of cents, and treatment for Hep C is around $84,000, and the lifetime treatment of HIV is around $400,000. So the return is very simple to see. And lastly, and probably most importantly, is that when people engage in a syringe service program, they are 5 times more likely to enter treatment. So instead of thinking about being ready to pursue treatment as when you get an assessment done, there's lots of steps before that are in a pre-contemplative or contemplative stage of change, where the syringe service programs are that safe place for people to go and engage in care at anywhere along the spectrum. So whether they're looking at safer use, reduced use, regulated use, or considering treatment, or getting into treatment, or preventing relapse, or maintaining recovery. Anywhere along the spectrum, a syringe service program is there. And I will note that most of the clients, so last year the MDH-funded SSPs served almost 7,000 unique clients, and these are clients that are not participating in other kinds of care. So they're not getting care in primary care. They might be going to the emergency room, but only for specific needs, right? And so this is a place where they can really start engaging on a ground level and have that safe place and somebody to go talk to if and when they're ready to pursue treatment and recovery supports. So these are the MDH-funded syringe service programs: Indigenous Peoples Task Force, Just Us Health, which is the merger of Rainbow Health Initiative and Minnesota AIDS Project, Native American Community Clinic, or NAC, North Point Health and Wellness, their program is called In and Out, Ramsey County Clinic 555, so it's embedded in their public health, and Rural AIDS Action Network, or RAN, in Duluth. And there's other syringe service programs throughout the state. White Earth Harm Reduction, Hennepin County Red Door, Southside Harm Reduction, which is a mobile service, Valhalla, RAN Mankato, and Northern Minnesota Harm Reduction in Grand Rapids. So in I want to go back. You had a question a while ago, I'm sorry. Yeah. Sure. Yep, so the question was about naloxone. So there's 3 different formularies available right now: the IM intermuscular, the nasal, and the auto-injector. So the IM, the intermuscular, is about $40 for a kit, and the nasal is about $200 for a kit, and the auto-injector is about $400 for a kit. So statewide, when we look at the STR, the State Targeted Response Grants that go out to community-based organizations, they're all distributed in the IM. And that's because, think of how many more people we can reach if we give that. And so the majority of people who are using a naloxone kit, they're not shy about needles. They're not concerned about that. There's also, some reason to believe that if somebody has respiratory depression, that the intermuscular might work differently than a nasal. Most people require multiple doses. There's different people have different averages. I've heard everything from 2 to 3 is the average, 4 to 5 is the average, depending on where they are. So does that answer your question? Okay. I brought a naloxone kit with me. I carry one at all times, so if anybody wants to see that or talk about that afterwards, I'm happy to show you that. So this graph is, again, from Dane's data, and it looks at, during treatment admission, you're asked, have you used injection drugs in the past 6 months? Have you injected? So this is a self-reported measure. But it has been consistent for many, many years, so it shows change over time. So on the left, you'll see 2007, and on the right, you'll see 2017. The darker colors are indicating higher levels of use. So on the left, there's only 3 pieces of the legend, okay? It caps out at 2 out of 1,000. So 2 out of 1,000 people were saying, yes, I have injected drugs in the last 6 months. On the right-hand side, the graph caps out at 44 out of 1,000. So just to show the exponential increase in injection drug use, keeping in mind, 1, this is a self-reported measure, so we know that it's underreported, and number 2, this is only people who already got connected to treatment and recovery supports. We did a vulnerability assessment for the rapid dissemination of HCV to help guide funding and policy decisions for interventions that prevent the spread of infectious disease. And this was replicated in analysis that the CDC did. And you can see which counties were at highest risk of rapid dissemination or an outbreak of hepatitis C. Then I want to spend a little time talking about social determinants of health. So on an individual level, there are all sorts of things that put people at risk for a substance use disorder, and there are things that protect people from substance use disorder or the related harms of drug use. So, for example, risk factors that may increase a person's risk for developing a substance use disorder are things like biology, genetics, substance use exposure during pregnancy, adverse childhood experiences, early exposure to drugs or drug-using contacts. And all of these things can accumulate over the lifetime. Then the protective factors are the things that mitigate the risks or create a buffer. These are things like simply having a person who cares about you, feeling safe, being able to talk to your family and loved ones about what is going on with you, feeling socially competent or feeling empowered to make choices or feeling like you have the capacity to make choices within your life. So anytime that we're looking at strategies, we want to look at what can reduce or eliminate any risk factor and what can strengthen or enhance any protective factor. So for each role, I think the question becomes, if you're a clinician, what can you do to reduce stigma of substance use disorder, let's say? Then looking at universal screening for all of your patients. So just take the stigma out of it, take the guessing, take the bias out of it, and every single patient receives screening for substance use disorder. Or if you're a police officer, how can you connect people who use drugs to someone who can help them navigate that referral to treatment? So connecting people to a syringe service program or things like that. Substance use disorder is rarely happening in isolation to other conditions and other harms. The realities of poverty, racism, classism, social isolation, sexual exploitation, and all sorts of other social inequities affect people's vulnerability to and capacity for effectively dealing with drug-related harms. So if we unpack this a little bit, imagine one person who did not get a criminal record as a result of their drug use and somebody who did get a criminal record as a result of their drug use. Which one of these people is in a better position to return to community life? We obviously know that having a criminal background is a huge barrier, especially if it's a felony, and an ongoing barrier to getting housing and employment. Or for example, imagine if one person has a really supportive family and they even set up a Caring Bridge site to help them, help people stay connected to what's going on with them during treatment and recovery supports. And then another person whose family has alienated them because of over the years, all the things that have happened. Again, the differences in the social support network between these two people, it's going to have an impact on their ability to maintain long-term treatment and recovery supports. So all of these things, there's just so many different interactions, and so I think a lot of times we hear people get frustrated, like, they went to treatment, why are they back out there using again? Or, how many chances are they going to get? Or some of these things, and I think we just really need to take into account the constellation of harms that surround these things and how complex it is. Substance use disorder affects employees, workplaces, families, and communities, and employers really have the opportunity to identify the early signs and symptoms of a substance use disorder and help to connect people to treatment and recovery supports. Substance use disorder impacts workplace safety, healthcare costs, productivity, absenteeism, and job performance. Not only are the individual employees affected by a substance use disorder, but any employee may have a child, partner, or family member who's struggling with a substance use disorder. So when employees respond to the opioid epidemic, it's impacting the employee and all the people around them. And so we really have the belief that recovery is good for business. And because of that, we worked with the Minnesota Business Partnership to create the Opioid Epidemic Response Employer Toolkit, which outlines 5 concrete actions that employers can take to be a part of the opioid epidemic response, and it's free for anybody to use. The Minnesota Business Partnership makes up about 25% of employees in the state of Minnesota, and so it's been disseminated that way, but it's available for any employee or employer to use, and it has these downloadable and customizable tools inside it, like emails, tweets, links to videos, and just small little actions that employers can take to open up the conversation. So these are the steps: change the conversation about substance use disorder, promote safe use, storage, and disposal, prepare for overdose emergencies with naloxone access and training, access treatment and recovery supports, and support wellness and become a recovery-friendly employer. So again, I just want to zoom back out to what we talked about at the very beginning, when we're thinking about all of the things that need to be done in that emergency response area, responding to an overdose emergency, naloxone administration, and then treatment and intervention, which is going to include infectious disease treatment and substance use disorder treatment, and then primary prevention and public health, like universal screening for substance use disorder and access to sterile syringes. So I wanted to stop there and be able to take a few questions and look at what things are you most interested in at this point, and we could do any of these things now or after the event. We can look up your overdose death data, we can watch more videos about naloxone, we can look for treatment openings in your area, can look up county level opioid prescribing, find the nearest safe drop box location, look at which pharmacies have syringe access, or actually look at the employer toolkit. So there's lots of concrete things we could do, or any other questions that you have.
And I've been told that because we're over time a little bit, we're only going to take a couple of questions.
Thank you for your talk. I was wondering if you could comment on the continued disparity between the Native American community and regarding, like, why does it continue in Minnesota? I noticed they have a syringe program. There was a Native community.
There's one tribe that has a syringe service program, yes.
What about their access to Narcan? I mean, what are some of the other factors where that disparity continues? State of Minnesota, where you're not seeing it in some of the other states?
So, how do I get this to stop here? Maybe close this. I want the PowerPoint to stop. Just 1 second. Maybe if I slide this over, there we go. Okay, and then I just have to go on here. Okay, so this is the opioid dashboard. And if you want to learn more about the race rate disparity, you go into drug overdose death, and under the narrative tab, there's a whole section on race rate disparity. We're really committed to not providing a short answer about that because it's extremely complex. So this report goes over who's included, how death is counted, a summary of all the findings of the race rate disparity, and then it breaks down every single data point and provides some background and context. So I'd really encourage you to go to that page to read more about it. Yeah, thank you.
Any other questions?
I have one.
Yeah.
Thinking ahead to the next opioid epidemic, what do you think, what are your thoughts about what could have prevented the aggressive marketing of prescription opioids?
Not really my area to comment about. So there's lots of factors that led into this, right? One of them being overprescribing of opioids and, like you said, marketing. That's just one of the many, many factors. And I think from a public health perspective, what we look at is if it's not opioids, it's something else. And so we're more looking at zooming up to talk about substance use disorder, pain, trauma, and suffering, preventing the demand for altering substances in the first place, no matter where that's coming from. The specific strategies around addressing marketing within pharmaceutical industries really isn't something that is within our scope. Thank you.
Can I ask I know we said 2 questions, but other than the syringe service programs, what else has been effective in addressing or has been promising as addressing the rates that keep seemingly growing of the opioid use, as far as response from not only maybe the Minnesota Department of Health, but if you see anything out of like federally, any legislation that's come out, anything like that?
So again, on the opioid dashboard, on this top link, it goes to learn more what's happening statewide in planning. So first it has the 3 sisters, then it goes through a bunch of examples of what would fall into these 3 buckets. So all of these things are needed and at the same time, right? So there needs to be access to naloxone, knowledge about Good Samaritan law, good transitions of care, syringe access, fentanyl alerts or this emergency preparedness for clusters of overdoses. All of that would fall into an emergency response. And then that middle part, treatment and intervention, that really falls mostly into Department of Human Services. So that's going to be expert services, screening, brief intervention, referral to treatment, medication-assisted therapy, so methadone, buprenorphine, naltrexone, OB care and infant care for neonatal abstinence syndrome, safe storage, safe disposal, all those things would fall into that middle sister. And then the primary prevention in public health is all of the upstream things. So what can we do to prevent the development of new addictions? So prescribing practices, safe disposal, preventing diversion, reducing marketing, enrollment and use of the prescription monitoring program, prevention of ACEs, adolescent risk reduction, pain management, addressing trauma, all these things. So there's been a lot of work on culture as prevention within American Indian communities, and there's currently legislation that's being considered around that. And looking at the integration of traditional healers, and traditional healers being a reimbursable treatment provider. There's, in terms of if you're looking at within our tribal nations, there's a harm reduction summit coming up in a couple of weeks that's up at White Earth. And it's the 7th annual harm reduction. And Monday and Friday is a tribal specific day, and then Tuesday, Wednesday, Thursday is open to anyone. So that's another area where that will be the focus. Yeah, thank you.
Okay, thank you, Kate, very much for your talk and sharing your knowledge. I wanted to also extend a thank you to